Okay. I'm hoping that soon you'll be able to hear me from this microphone. Hearing me now? But I'm not hearing it out there. Are you all able to hear me? No. It's on? Well, I've been reassured that you're supposed to be hearing me in the room, but in the event, oh, I'm hearing me now. Wonderful. So, a pleasant good afternoon, everybody. My name is Abigail Harrison, and I have been tasked with walking us through as moderator this afternoon. I'm a little charged. I think my blood sugar is low, and so I'm highly charged, so beware. So I am exceptionally pleased to be here this evening because approximately, wow, what's that? Maybe 15, 20 years ago, a lady who is about to come and speak with us and bring greetings as the dean of this awesome faculty made sure I got bitten by the research bug. So it's her fault that I'm here. So this afternoon marks our second Residents Research Forum. And though my residents are looking awesome, handsome, and beautiful, all of them, I'm sure some anxieties buzzing over there, but they're going to be great because they've done excellent work. So to start us off this evening, I'm going to welcome the Dean of our faculty and a pediatrician, Professor Minerva Thame.
And you forget to say, always belonging to child and adolescent health. Good afternoon, our moderator, Dr. Abigail Harrison, Professor Russell Pear, Head of the Department of Child and Adolescent Health, our residents, colleagues, all, good afternoon. It gives me great pleasure to be giving this opportunity to bring greetings at the second staging of the Residents Research Forum. I continue to be very proud of the Department of Child and Adolescent Health as they continue to push the research agenda and contribute significantly to the research output of the Mona campus. We have insisted that our residents must do research to ensure a rounded, well-trained consultant. Research is a vehicle that we use to gain new knowledge and to guide our practice. Evidence-based medicine is what should allow us to decide how we do things and why we do things the way we do. Our practice should have its foundation rooted in hard evidence, and this can only be accomplished through conducting research to guide us. When we changed our program from having residents do casebooks to conducting a publishable piece of work, it was met initially with resistance from some departments. But this department, who was already seeing residents do a piece of research for them to qualify to do their DM exams, embraced it. This practice has seen the Department of Child and Adolescent Health as one of the leading departments in the faculty in research, as many of our residents go on to publish their work with their supervisors. The introduction of research in this manner also was to take our residents through the process of asking a question, creating a proposal surrounding that question, engaging the process of getting it accepted by ethics, collecting and analyzing the data, and then finally writing this up. This process gives structure to the practice of conducting research. As we engage in research, it is important that we recognize the importance of not only conducting the research, but to interpret the studies that are published within the literature. It is important for our residents to be able to dissect information and ensure what is being presented is indeed valid and based on sound method. Our residents must develop the ability to decipher which studies are properly conducted, whether the sample size is adequate to substantiate the claims that are being made, and if the conclusions drawn from these studies are in keeping with the research work that has been carried out. So for that reason, journal clubs, which is a part of our program, is also an important forum for residents to interrogate the research. When research is carried out, it's important that we share the findings, and this research forum has created that platform for this work to be showcased by our residents. Too often, good research is conducted, which is not shared with our peers. This forum will also serve to spark ideas and to generate other questions, which will fuel further research. I look forward to hearing the residents' presentation on the stellar work that they have conducted, and I urge the next step, which is to get it published. I once again would like to congratulate Professor Pear and his team for carrying out this very important initiative, and I look forward to this afternoon's proceedings. Thank you very much.
Thank you very much, Dean Thame. So this department is blessed by having many professors, many of whom are here, and I count myself very fortunate to be a member of a department with so many professors in it. But I'm now going to call on our head of department, Professor Russell Pear, to bring his greetings.
Moderator, Dean Thame, distinguished guests and residents, good afternoon. It is really and truly my great pleasure to welcome you all to this year's Resident Research Forum hosted by the Department of Child and Adolescent Health. Today, we come together to hear our finalizing DM residents share the findings from their research project reports. This is the second staging of this event as we promote dissemination in this dedicated forum as a department. This forum is a celebration of the tireless efforts and dedication of each and every one of you residents who have been working hard to reach this milestone in your finalizing year. You have already received communication from graduate studies through me that you have all passed the evaluation of the research reports. As healthcare professionals and researchers, we are driven by the pursuit of knowledge and the desire to make a positive impact on society. Your work has the power to transform lives, solve complex problems, and create a better world for generations to come. And this forum provides an opportunity for us to come together and share our knowledge, insights, and expertise. I would like to take this opportunity to express my sincere gratitude to the planning team, the judges, participants, and our sponsors, Abbott Nutrition, and the Faculty of Medical Sciences Dean's Office, and all who have made this forum possible. Your support has been instrumental in enabling us to gather here today and showcase our residents' research to our stakeholders. Finally, I'd like to wish you all a productive and enjoyable evening. Let us take advantage of this opportunity to learn, to grow, and encourage our finalizing DM residents in their pursuit of excellence. Thank you all for being here in person and for those who have joined us remotely. Thank you.
Thank you very much, Professor Pear. So we're moving now into the exciting part of the evening, where we'll actually hear from our residents who will be sharing with us details on their clinical research projects for the DM Pediatric program. Just so that everybody will be aware, they have 10 minutes within which to present. And at the end of approximately half of them, then we'll pause for question and answers, and again at the very end. Okay? So have your paper and pen ready to put down any questions that you may have. Or I guess you could type it on your phone, and those at home on the YouTube stream or en route to home, then you also can put your questions in the chat when it's that time. So it's my pleasure to introduce our very first presenter, Dr. Alistair Carvalho, who hails from the middle of the country in Trelawney, and who attended William Knibb, went on to the college, Cornwall College that is, studied in Cuba, and then returned here. And his topic today is very suitable as he intends to become a neonatologist. Am I correct, Dr. Carvalho? Awesome. So I'm going to ask Dr. Carvalho to come and speak to you on hypoxic ischemic encephalopathy, incidence, outcome at discharge, and predictors of poor outcome, a retrospective study of a Jamaican cohort. Please welcome him.
Good evening, everyone. My name is Alistair Carvalho, and I am very pleased to be here today to present my research topic. Thanks a million to the pediatric team, and I am going to start with my title, Hypoxic Ischemic Encephalopathy, Incidence, Outcome at Discharge, and Predictors of Poor Outcome, a retrospective study of a Jamaican cohort. Thanks to my advisors, Professor Helen Trotman-Edwards and Dr. Gillian Lewis. I have no disclosures, and I will jump into my introduction. So hypoxic ischemic encephalopathy is a form of brain injury in newborns resulting from reduced oxygen supply and restricted blood flow. It is characterized by diminished consciousness, seizures, and challenges in respiratory function, often accompanied by decreased muscle tone and reflex responses. HIE is a global problem. Several studies have provided insight into its incidence, outcome, and predictors of outcome in neonates diagnosed with hypoxic ischemic encephalopathy. However, there is a paucity of recent data on these factors out of Jamaica. From these studies, the incidence of HIE in most instances remain lower in developed countries than in low and middle income countries. The predictors of outcome are similar across both developed and low and middle income countries. However, there is a wide variety of predictors of outcome. And I've listed a few, including blood gas parameters, abnormal brain MRI, abnormal neurological examination at discharge, just to mention a few. My objectives today would be to go through to determine the incidence of hypoxic ischemic encephalopathy in neonates at or greater than 36 weeks gestation born at the UHWI between January 1, 2018 and December 31st, 2022, to identify the outcome at discharge and predictors of poor outcome in neonates at or greater than 36 weeks gestation diagnosed with hypoxic ischemic encephalopathy at the UHWI between January 1st, 2018 and December 31st, 2022. And lastly, to compare the incidence of hypoxic ischemic encephalopathy in this study with that of a previous study done at the UHWI between January 1st, 1998 to December 31st, 2003. This was a retrospective descriptive docket review looking at all neonates at or greater than 36 weeks gestation with hypoxic ischemic encephalopathy born at the UHWI within the time period specified. Descriptive analyses were performed and differences in neonates by the Sarnat staging and outcome were determined using the chi-squared for categorical variables and one-way ANOVA for continuous variables. Predictors of outcome were determined using multiple logistic regression models. Data were analyzed using SPSS software, and statistical significance was taken at the level of p less than 0.05. So a poor outcome was defined as either mortality or significant neurological sequelae indicated by an abnormal neurological examination at discharge or abnormalities observed in brain imaging, whether it's a cranial ultrasound, CT brain, or magnetic resonance imaging. An abnormal neurological examination at discharge was described as having an altered level of consciousness and activity, abnormal muscle tone, signs of bulbar dysfunction, and or evidence of neurological deficits. So jump into my study results. Of the 8,226 neonates that were delivered during this time period, 32 fulfilled the criteria for this study. A total of 11 neonates had hypoxic ischemic encephalopathy, HIE stage 1. 13 had HIE stage 2. 13 had HIE stage 2, and 8 had HIE stage 3. The overall incidence of HIE was 3.90 per 1,000 live births, of which 1.34 per 1,000 of live births were mild HIE, 1.58 per 1,000 live births were moderate HIE, and 0.97 per 1,000 live births were severe HIE. Of the 32 infants in the study, 5 died and the rest were discharged home. All neonates diagnosed with HIE stage 1 survived. 4 of the 5 who died had HIE stage 3, while 1 had HIE stage 2. The median age of death was 28 days. Of the 27 neonates who survived, 20 of the 27 had a normal neurological examination at the time of discharge. The majority of neonates with normal neurological examination at discharge had HIE stage 1. 7 neonates had an abnormal neurological examination, of whom 4 of the 7 had HIE stage 2, and the remaining 3 had HIE stage 3. No infants with HIE stage 1 had a poor outcome. In those with HIE stage 2, 5 of the 13 infants had a poor outcome. For those with HIE stage 3, the majority, 7 of the 8, had a poor outcome. These are factors associated with poor outcome, and these included the parameters of acidosis, which were associated with poor outcome as mentioned, which included the mean potential hydrogen, mean pH, which had a significant p-value of 0.004, the mean bicarbonate, which had a mean p-value of 0.023, and mean base deficit, which had a p-value of 0.009. Other factors associated with poor outcome included the need for ventilation, for mechanical ventilation, and we saw that mechanical ventilation was needed in 20% of infants with good outcome and 75% of those with poor outcome. And this was statistically significant with a p-value less than 0.01. 9 neonates received therapeutic hypothermia. 4 had HIE stage 2 and 5 had HIE stage 3. Of the 5 neonates who died, 3 received therapeutic hypothermia. The stage of encephalopathy and abnormal neurological examination at hospital discharge were significant predictors of poor outcome in this study. The overall incidence of HIE at the UHII decreased from 6 per 1,000 live births in the previous study done between 1998 and 2003 to 3.9 per 1,000 live births in this study. The difference was statistically significant with a p-value of 0.04. The incidence of HIE stage 1 decreased from 1.80 to 1.34 per 1,000 live births. The incidence of HIE stage 2 decreased from 2.46 to 1.58, and that of HIE stage 3 decreased from 1.68 to 0.97. My conclusions: the incidence of HIE between 2018 and 2022 was 3.9 per 1,000 live births, which represent a significant decline over the past 2 decades. 30% of neonates experience a poor outcome, and factors associated were therapeutic hypothermia, severe acidosis, and the need for mechanical ventilation. And significant predictors of poor outcome were the severity of encephalopathy and an abnormal neurological examination at hospital discharge. The study was a retrospective one, therefore there were limitations, included missing or unavailable medical records at the time of data collection. 10 dockets were not available for review. However, supplemental data sources were used to capture some of the data. Data obtained may have been incomplete due to being limited by what was recorded in the medical records. A lack of amplitude integrated EEG, electroencephalography, could signify subclinical seizures went unrecognized, which would affect the validity of the HIE staging that was assigned. There was also the inability to obtain neuroimaging as promptly as we would have wanted. Therapeutic hypothermia was only utilized from year 3 of the study, and this may have impacted neurological examination at discharge. This was a single-center study conducted at a tertiary level university-affiliated institution where the women who accessed care were more likely to be employed and more likely to be in a stable relationship, and this study would have been, as a result of that, the results may not be able to be generalized to other centers in the country. My recommendations include augmenting the quality of intrapartum care services, implementing interventions such as continuous fetal monitoring for high-risk patients, and introducing fetal scalp pH testing in labor and delivery units. I would also want to recommend implementation of amplitude-integrated electroencephalography, timely neuroimaging for infants diagnosed with HIE, and I think the need for further studies to determine the impact of therapeutic hypothermia is significant. I would like to pay special thanks also to Dr. Oligboyi, who was very instrumental and who provided a lot of support during the construction of this research, to my family, friends, and colleagues. These are my references, and thank you very much for listening.
Thank you, Dr. Carvalho. I think you moved through that very smoothly, and my apologies for the slight disturbance. Okay, I'm going to just remind everyone to just take note of the questions you wish to ask later on so that we'll be able to move smoothly along. So next up is another of our fourth-year residents, Dr. Venetia Cruikshank Reynolds, who is a graduate of the St. Andrew High School for Girls. Went on to do her undergraduate studies at University of the West Indies here, and who loves to volunteer in the community. So she has the heart of a pediatrician, it seems. She's going to be talking to us today on unconjugated hyperbilirubinemia at the Bustamante Hospital for Children over a 3-year period. Dr. Cruikshank Reynolds. Please welcome her.
Good afternoon, everyone. Thank you. So I'm here to speak about my research project entitled Unconjugated Hyperbilirubinemia at the Bustamante Hospital for Children over a 3-year period. And my supervisor was Dr. Cindy Roden Graham, who is a neonatologist at the Bustamante Hospital. So the yellow baby. Many Jamaicans, if not all, know about the yellow baby, right? And there are many myths associated with jaundice. Some say it's because the sugar levels are high. I think that's the most common myth. But really and truly, it is one of the most common reasons for medical intervention in the neonatal period worldwide. And it is a significant burden in Jamaica. And it is the yellowish discoloration of the skin and mucous membranes in our neonates. So there are 2 distinct types, unconjugated or conjugated, and there's also physiologic and pathologic. For the purpose of my study, I focused on unconjugated and the pathologic type. So this study was birthed as there were no recent epidemiological studies found on neonatal jaundice in the English-speaking Caribbean. So this study aimed to provide epidemiology, as we thought it would be useful in decreasing the burden of disease in our population. We aimed to determine the prevalence of UCH over a 3-year period from the time period seen here, and to document the epidemiology of our neonates, the nature of intervention received, complications from therapy, and outcome at discharge. All neonates with UCH at our institution requiring medical intervention were selected, and a chart review collecting demographic, clinical, and laboratory data was completed. A retrospective descriptive analysis was performed using the statistical package for social sciences software. And we calculated our prevalence by using this equation, and with this, our required sample size was supposed to be 203. This flow chart shows how we arrived at our study number. So over this period, over 2,000 neonates were admitted, but only 386 of which had neonatal jaundice. And then only 115 of this figure went on to require medical intervention. So the pie charts here show that the majority of our neonates were male and term, and most of which had a normal birth weight, and the mean birth weight was found to be 3 kilograms. This pie chart showed that we were able to get the blood group for only 99 of our neonates, and majority were O. They were rhesus positive and DCT negative. This pie chart shows that majority of our neonates were noted to be jaundiced between day 6 to 7 of life. Even though of this number, majority of our neonates were admitted between day 6 and 7, which is outside of the period when they were first noticed to be jaundiced. So only about 31% actually presented within the period that we noted they had jaundice initially. Majority of our neonates were breastfed, that is 68%, 26% of whom showed signs of dehydration on presentation, and 7% had abnormal neurological signs. All our neonates required phototherapy, and this pie chart shows the total serum bilirubin on admission, where majority of our neonates, as I mentioned, would have presented in phototherapy range, but a few of our neonates developed neonatal jaundice while admitted to our unit. Then this bar graph shows our findings that was in keeping with the worldwide data that majority of the cases are unknown. And then that which we identified, ABO incompatibility, was the most common cause at 26%. This was seconded by breastfeeding jaundice. Then as we see, G6PD came in at 3%, but we really don't believe this number because our testing at Bustamante Hospital is very limited, as the test is not available in a public service and most of our parents are unable to afford it. This table shows that all neonates received phototherapy and majority required double light phototherapy. No neonates, thankfully, required exchange blood transfusion, and even though phenobarbital and albumin are no longer recommended for NNJ treatment, in resource-limited settings as ourselves, we do continue to find that the need is beneficial. This table shows some associations that we explored. So for our neonates with immune disease, they did not have a longer stay in hospital than those who did not have immune disease. And for those who were treated with intravenous immunoglobulin, they also did not have a longer stay in hospital than those who were not treated with that modality. This table shows that the time from discharge to readmission, It shows that neonates who were discharged earlier from their birthing hospital were younger upon admission for neonatal jaundice, meaning that if you were discharged early from your birthing institution, you were presenting to Bustamante Hospital much sooner with neonatal jaundice, and that was a finding that we expected. Thankfully, there were no complications from any of our treatment modalities, and there were no deaths in our study. One neonate, however, showed signs of bilirubin encephalopathy on discharge. Unfortunately, we did not get the required sample size necessary as we calculated. However, we do believe that this study can be used as an interim analysis on the topic, as it may aid in formulating prospective studies. And there was also missing data from lack of documentation. We do believe that the common association identified underscores the need for targeted intervention and heightened awareness in maternal and neonatal care. The lack of documented age at discharge from birthing hospital and the high proportion of cases admitted on day 6 to 7 of life highlight the potential challenges in early detection of NNG and intervention. Despite no deaths in our study, continued research in the area and increasing the knowledge base of the general populace on NNG are essential for the prevention of NNG and effective management in the Jamaican neonatal population. We do believe that a public campaign on NNG would assist Jamaicans in knowing about the disease and the importance of seeking medical attention early for same, thereby decreasing the burden on families, the hospital, and at large the community. And we do also believe that more public funding needs to be invested in testing for G6PD deficiency, as we do believe we're missing a lot of our cases. And we see here, this is our phototherapy treatment. These are my references, and I thank you for your attendance and for listening.
Thank you, Dr. Cruikshank-Reynolds. I think we moved through very smoothly there, and we're grateful for that. Okay, so next up, the last for the session one is Dr. Alison Isaacs, also from St. Andrew High. Wow. But she also spent a stint at Hampton High. She's a member of the class of 2014, and she loves enjoying her traveling with different cultural experiences and the beach. Hopefully you'll soon have more time for that. So please welcome Alison this afternoon. She's going to speak on growth patterns in premature and term infants.
Good afternoon, everyone. I'm Dr. Alison Isaacs, and today I will be presenting my DMP's research topic entitled Growth Patterns in Premature and Term Infants. It was a case control study. Primary investigator was Professor Minerva Thame, and Dr. Georgiana Gordon-Strawn and I were the co-investigators. Nutrition and growth in the first 1,000 days of life has recently been found to be a determinant of long-term cardiometabolic outcomes. Prematurity, which is birth before 37 completed weeks of gestation, has been associated with an increased risk of excess weight, high blood pressure, and glucose dysregulation much later on in life. So we wanted to look at growth of term and preterm children over the first 2 years of life and compare them. Also, we wanted to assess nutritional knowledge, attitudes, and practices of primary caregivers of these study infants. We also wanted to look at and compare blood pressures of term and preterm infants at 2 years old. It was a case control study, and ethical approval was obtained from the Mona Campus Research Ethics Committee. So we looked at 2-year-olds with a history of being delivered at a gestational age of 24 to 36 weeks. Those were our cases. They were premature. And at a gestational age of 37 weeks or more are controls born at term. Our initial protocol involved an approach where we would approach the caregiver and caregiver and child dyad, confirm the relationship of the caregiver to the child, and confirm the age of the child. Informed consent was obtained, a questionnaire was administered by the researcher, and the child's blood pressure was taken. Data extraction from the child health passport was done, followed by a short educational session. The data we extracted from the passport included the weight, length, head circumference at birth, 6 months, 12 months, and 24 months. One of the challenges we encountered during the study was an inadequate number of preterm infants presenting to clinic, and what we did was to review electronic records of the premature clinic to collect the necessary anthropometric and some nutritional data for our preterm infants. We used SPSS version 18 for data analysis. We calculated our means, proportions, standard deviations. The chi-square test was used to compare categorical variables, and the student's t-test was used to compare continuous variables, and a p-value of less than 0.05 was deemed to be statistically significant. We had a total of 101 participants, 44 cases, and 57 controls. Of our cases, 18 were obtained prospectively, 26 were obtained retrospectively, and all of our controls were obtained prospectively. With respect to the mean gestational age at birth of the two groups, for the boys, preterm babies were 31 weeks and 6 days on average at birth, and for the term boys, 38 weeks and 6 days. For our girls, 31 weeks and 3 days for the preterm, and 38 weeks and 5 days for the term babies. What did we find? So we found that by their first birthday, there was no difference in weight between preterm and term boys. So they had caught up in weight by the time they were a year. Preterm girls, on the other hand, continued to weigh less than term girls up to and at 2 years old. And this was statistically significant with a p-value of 0.04. With respect to length, preterm boys and girls were shorter than their term counterparts at 2 years old, and this was about by 2 inches in each case. With respect to head circumference, preterm boys and girls attained head circumferences equal to their term counterparts by their first birthday, which is a good sign for neurodevelopment. We also looked at BMI at 2 years, which we found preterm boys had a higher BMI at 2 years when we compared them with term boys, and this was statistically significant with a p-value of 0.02. However, there was no statistically significant difference between the BMI at 2 years between preterm and term girls. When a child gets to age 2, we're able to calculate their BMI, and the CDC, Centers for Disease Control and Prevention, has percentiles from which we can assign weight categories to our children. For preterm boys, none of them was categorized as underweight. In term boys, 40%, when we use the CDC growth chart, 40% of them were categorized as underweight. And we just wanted to highlight the difference when the WHO's weight for length chart was used. When the weight for length chart was used, a Z-score of less than -2, which would indicate underweight, no preterm or term boys, no boys at all, were classified as underweight. When we use the CDC BMI chart, 23% of preterm boys were classified as having excess weight, and 8% of term boys were classified as having excess weight. When we use the weight for length chart, 15.4% of preterm boys and 8% of term boys were classified as having excess weight. Looking at the girls, 43% of preterm girls and 37% of term girls were classified as underweight when we use the CDC BMI chart, compared with 9.5% and 11% respectively when we use the WHO weight for length chart to look at underweight. looking at practices. So we also looked at the duration of exclusive breastfeeding as well as the total duration of breastfeeding. We found that there was no difference between preterm and term babies related to breastfeeding. Where we did find a difference, however, was the introduction of complementary feeds. Preterm babies were more likely to have an inappropriately early introduction to complementary feeds. And that was statistically significant with a p-value of 0.01. There was no difference in caregiver knowledge between those of preterm and term infants. And with respect to blood pressure, there was no statistically significant difference in blood pressures of term and preterm infants at 2 years. However, we have reason to suspect that there is clinical significance because 25% of our preterm babies were referred for blood pressure evaluation compared with 12.1% of our term babies. In conclusion, preterm boys are at highest risk for excess weight at 2 years old. At 2 years old, preterm girls and boys are about 2 inches shorter than their term peers. Preterm boys, specifically, are more likely to have inappropriately early introduction to complementary feeds. And from this, we can recommend anticipatory guidance about appropriate introduction of complementary feeds at discharge from the nursery and at the first visit to prematurity clinic. And blood pressures of preterm infants should be routinely measured at visits to the prematurity clinic. Limitations of this study: the participants were from the University Hospital of the West Indies only, which means that there is limited generalization to the Jamaican population. We also used retrospectively obtained anthropometric measurements, which introduces variability, and there was missing anthropometric data from passports, and it was a small sample size, which again limits generalization. Thank you for your attention.
Thank you very much, Dr. Isaacs. Okay, so we've just completed session 1. I think we can give all our presenters a round of applause again. They were excellent, 3 very good studies. And I'm going to open the floor now. We are monitoring our online colleagues for their questions. And I'm going to open to the audience here first. I'll give you dibs for questions. I see a hand. Go ahead, Prof. Christie.
Want to congratulate all of the presenters in this neonatal session. My question, however, is directed to Dr. Carvalho. And I just wondered, what were the factors that contributed to a reduction in HIE over time? Is it the patient population that changed? Is it the interventions that changed? Anything else?
Okay,
Thank you
so much. Okay, thank you so much for your question, Professor Christie. I believe that based on the results that we collected, that a reduction in the incidence of HIE wasn't attributed to one single thing. I think it was a combination of factors inclusive of the population in itself, the fact that better care was being taken during the antenatal period, and I believe that the intrapartum period where we had continuous fetal monitoring, we had prompt cesarean sections being done, I think all of those contributed to the reduction in the incidence of hypoxic ischemic encephalopathy. Thank you.
Thanks, Dr. Carvalho. I'll come back to you. Prof. Pear, I'll get a microphone to you shortly. Maybe just pass it down the line. Thanks, Brittany.
Thank you so very much. Thank you all residents for the presentations. Very, very well done. So I had 2 questions, but Prof. Christie preempted one of my questions, which is a very important question. But my second question is to Dr. Isaacs. Did you explore any reasons for the inappropriate early introduction of complementary feeds in the preterm infants compared to the term ones?
Thank you for the question, Prof. So at the time of doing the study, we didn't have that information, but so we weren't able to explore the reasons for that. We explored other cultural norms or thought patterns as it related to, does a parent think that a chubby child is healthier? Does a patient or just prefer seeing a chubby child, right? But we weren't able to ask specifically about why complementary feeding was introduced inappropriate early in preterm.
One other question. Was there a difference? Was it more in the males than in the females?
The inappropriate complementary, yes. And
Very important question.
yes,
Explore in qualitative analysis.
yes. Okay.
Okay, thank you.
Thanks. Just for those who were online who may not have heard Professor Pear's question, he was just clarifying whether the premature start of complementary feeding was more in boys than girls, and it was. That was the response. Prof. Trotman, then Dr. Melbourne Chambers, and then Dr. Lewis.
Okay, so again, let me compliment all the residents for excellent presentations. My questions to Dr. Isaacs. I noted that for the premature infants, I can't remember the number, but a greater number you had gotten the information retrospectively. So for those, you would not have had the questionnaire, the parent questionnaire. So I noticed that that number of preterm infants would be very small, and I just wonder whether, you would have had enough, because it's small, that's one. Two, did you all do, in your analysis, did you all do any, did you all take into consideration that you all were looking at multiple measurements over time, because you were doing multiple measurements over time? So did you all take that into consideration? And of course, your controls were from the Well Baby Clinic, is it?
Yes, they were.
And the other one from the Prem Clinic. So the others from the Prem Clinic. So again, in terms of our measurements, there are two different clinics, and those multiple measurements are made by different people. So did you all take that into consideration?
Okay, I'll address the last question first. And so what ended up happening, although we intended to get all the preterm babies from the prematurity clinic, if a preterm baby presented to Well Baby, that baby was also included in the preterm cohort. And the anthropometric data we used was from the Child Health Passport, which is typically not written in at the Prem Clinic, but it's usually written in at the Well Baby Clinic when those babies come for their routine assessment. That's true, right? You had asked another question about the numbers. I agree with you, because we had about 18 babies obtained prospectively, and then 20 in the 20s obtained retrospectively. What we're able to do is to look through at the nutritional history for some of them to see when complementary feeds were introduced. So I agree with you that that is a limitation, right? Okay, thank you.
Thank you. Dr. Melbourne Chambers, go ahead.
Thank you. Congrats to all the presenters so far. My question is for Dr. Carvalho. So I understood that therapeutic hypothermia was associated with a poor outcome, and I was just curious as to whether or not of those with therapeutic hypothermia who died, were many of those of a more severe HIE category, like stage 3.
Okay. Thank you for that question, Dr. Melbourne Chambers. So indeed, those patients, so even though there is an association with poor outcome and therapeutic hypothermia, there wasn't a direct effect. meaning therapeutic hypothermia was not the reason for the significant mortality. Just to clear that up. It just so happens that those babies who received therapeutic hypothermia, they were very sick babies, and the outcome would have been basically the same.
Thank you, Dr. Carvalho. Dr. Lewis, you had a question. This will be our last live audience question.
Thank you for the opportunity, and thank you for some really excellent presentations. Dr. Carvalho, I've got a follow-on question from Dr. Melbourne Chambers' question. So, we've spoken about a study that was done in Pakistan that suggested that there was a direct link with therapeutic hypothermia and increased mortality. And so you mentioned that there is an opportunity for additional study based on your findings. So have you got any suggestions about how that could be approached?
Definitely. Well, perfect opportunity to inform the public at large that we started therapeutic hypothermia at the University Hospital in February 2020. And so far, we have successfully cooled a significant amount of patients, and we have seen where the outcome at discharge has been markedly significant, and it has been amazing in terms of the results that we have seen so far. I would say we encourage our research in that particular area, and yes, we encourage our research in that particular area, and I think in a few months that topic will be that topic will definitely be assumed by one of the residents. Thanks for that question, Dr. Lewis. Okay, so the purpose of the intervention, thank you for that question, Professor Christie. So essentially what therapeutic hypothermia does, if it started early, which is usually within the first 6 hours of life, it usually improves neurodevelopmental outcome. We have seen where basically you're trying to decrease the metabolic demands of the neonate and to prevent further neuronal damage, which you would experience without such a procedure. Okay, you're welcome.
We have Dr. Carvalho on the file today. Thank you, Alistair. We had one quick question online, which was to just clarify what was the time period Dr. Isaacs used for early introduction of complementary feeds. What did you use? Just tell me. Was before 4 months. Thank you very much. Okay. I think the moderator was naughty and we went over our 10 minutes for questions and answers, but we're going to get back on track now with session 2. Thank you very much for your questions. So next up, we have one of our residents hailing now, again, our second resident from Bustamante Hospital for Children, and this is Dr. Lauren Shaw, not an Andrews graduate. She's actually hailing from Campion College, and she has an interest in critical care and transport medicine. Yay, Dr. Lewis, you have somebody to follow on. But today she's going to be doing the critical care part, looking at diabetes mellitus and diabetic ketoacidosis in children during the COVID-19 pandemic at the Bustamante Hospital. Dr. Shaw.
Good evening, everyone. I'm Dr. Shaw. I'm pleased to share with you today a snapshot of my research project. I had the honor of collaborating with Drs. McNeil Beechaw, Young Peart, Fulford Ramdale, and Richards Dawson. Together, we chose the topic, diabetes mellitus and diabetic ketoacidosis in children during the COVID-19 pandemic at the Bustamante Hospital for Children. I'd like to thank my primary and co-investigators for their support in completing this project, and I'd also like to thank the department for the opportunity to share this project. The rationale for our topic was that we had noticed an increase in the incidence of the newly diagnosed cases of type 1 diabetes, as well as an increase in the severity of cases that were presenting to the Bustamante Hospital for Children. Type 1 diabetes is a metabolic disorder affecting less than 1% of the pediatric population. This apparent increase piqued our interest, and we took our cue from the rest of the world, where they had started to examine causation between type 1 diabetes and COVID-19. There was already a significant body of evidence that had proved or that had suggested that there was no causation between SARS-CoV-2 and type 1 diabetes. However, there were thought to be sociocultural factors that were contributing to the increase in incidence that was seen. We noticed, however, that there was a lack of regional and national data on this topic. So we took a slightly different tack. We aimed to determine whether there was an increase in the incidence of new onset type 1 diabetes and diabetic ketoacidosis. And we also wanted to determine whether there was an increase in severe diabetic ketoacidosis in children under the age of 12 years at the Bustamante Hospital for Children during the pandemic. In terms of our objectives, we wanted to identify all new cases of type 1 diabetes in children presenting at the Bustamante Hospital for Children between the 1st of March 2018 and the 31st of March 2020, and between April 1st, 2020 and April 30th, 2022. As you can see, we divided our study period into pre- and post-pandemic, and this was done. The time period was chosen in light of the first pediatric case of COVID-19 being identified in April. Our second objective was to describe the epidemiology of patients presenting to the Bustamante Hospital for Children with type 1 diabetes and diabetic ketoacidosis during the period between March 1st, 2018 and April 30th, 2022. Lastly, we wanted to compare the presentation of patients with type 1 diabetes and diabetic ketoacidosis in the pre- and post-pandemic periods. All patients who met the diagnostic criteria for type 1 diabetes and or DKA were included in the study, as long as they presented during the study period and were under 12 years old. I will just say that sometimes we do see patients who are over the age of 12 to facilitate their transition to adolescent care. For the purposes of the study, our patients were defined as those who met the ISPAD clinical practice consensus guidelines on type 1 diabetes diagnosis without autoantibody positivity. And this was a criteria that was geared towards making the diagnosis in resource-limited settings, such as ours. In order to be diagnosed, a patient would have to meet the criteria for diabetes, but also to be over 1 year of age, to have no features of insulin resistance, and to either be non-obese or to present with ketosis. We conducted a retrospective study in the study period as previously mentioned. We obtained ethical approval from both the University of the West Indies Mona Campus Research Ethics Committee and the Ministry of Health and Wellness Medical Legal Affairs panel, based on the fact that this study was conducted at a public institution. Statistical analysis was performed by descriptive analysis, and continuous variables were examined using independent students' t-test, and categorical variables when compared using Pearson chi-squared test. In terms of our study population, there were a total of 33 participants, and this represented 65 presentations, as those who presented on more than one occasion were counted on each presentation. There were a total of 17 males and 16 females in our study, and their ages ranged between 2.35 and 11.98 years, with a mean age between 9.32 and 2.36 years. Fewer patients presented from outside the region during the pandemic, and fewer patients also presented without referral. The mean age at presentation was lower during the pandemic, and this was found to be significant for all presentations, as well as for age at first diagnosis of type 1 diabetes. We also noted that no other epidemiological data was of clinical significance during the course of our study. There were, however, some findings that were quite different, but not significant. There was an increase in the frequency of symptoms associated with severe disease and an increase in the duration of classical symptoms of type 1 diabetes. We also noted an increase in the duration of symptoms of severe disease. There was a reduced mean duration of admission noted, as well as an increase in both antibody testing as well as antibody positivity. There was no statistically significant increase in the number of patients newly diagnosed with type 1 diabetes during the pandemic. So in terms of the incidence of type 1 diabetes before and after the pandemic, there were 3 cases per 10,000 persons before the pandemic and 4 cases per 10,000 persons during the pandemic. DKA incidence was noted to be 1.6 per 10,000 persons before the pandemic and 3.1 per 10,000 persons during the pandemic. So our study confirmed the rising incidence of type 1 diabetes despite the lack of recent data comparing same. The lack of significant increase in type 1 diabetes incidence was possibly due to cultural factors related to health-seeking behaviors during the pandemic, as well as the attitudes of our patients and parents to the COVID-19 containment measures. Family history of type 1 diabetes was not found to be protective against DKA in our population, and this possibly highlights poor health education and literacy among our population. And this was also suggested by the prolonged duration of symptoms, including those of severe disease, that was found. Findings suggestive of poor lifestyle factors were not as influential in our population, and this is likely due to the fact that this population at baseline suffers from certain constraints. So the incidence of type 1 diabetes and DKA increased during the COVID-19 pandemic, but there was no increase in the severity of DKA at presentation. Having proven an increase in the incidence, we now have an opportunity to conduct further study with regards to other institutions across the island, as well as examining health-seeking behaviors at baseline of our population, as well as during times of disaster. We also have an opportunity to examine the healthcare system under stress. Our study also highlights the need for a registry of patients living with type 1 diabetes, as well as for improved resource allocation, including at the legislative level, to provide resources to care for these patients, as well as to provide opportunities for patient and parent education, and empower them to further manage themselves in the new sociocultural environment, which has become normal since the pandemic. Thank you for listening.
Thank you for moving through swiftly and smoothly, Dr. Shaw. Okay, so we're going to move on now to the first of our 4 Bahamian residents, Dr. Rodney Green, who disappointed me by wearing very normal socks today, is really the current comic in our group who brings a lot of vibes to the space. And interestingly, is also going to be pursuing critical care, just like Dr. Shaw. So I hand over to Dr. Rodney Green to talk to us on culture-positive neonatal infections.
Good day. So my name is Dr. Rodney Green, and my co-authors were Dr. Kemba Fowler, Dr. Anthony Frankston, and Mr. Alfonso Blake, and I'll be presenting the incidence of culture-positive infections in neonates admitted with a diagnosis of rouleau sepsis at the Princess Margaret Hospital in Nassau, Bahamas between April 2019 and 2023. So neonatal infection refers to any infection diagnosed in the neonatal period, and it can be bacteremia, meningitis, urinary tract infection, or pneumonia. Neonatal infections can also be divided in terms of the time of presentation, which can be early onset, which is usually before 72 hours of life, and generally, this is due to the transmission of pathogens from the female genitourinary system to the newborn. Neonates can also become infected during uterine delivery process as they pass through the vaginal canal. And typically, the bacterial pathogens seen are group B strep, E. coli, Coagulase naeve staph, and Haemophilus influenza. And then for late presentation, it's usually at or greater than 72 hours of life, and it usually occurs via transmission of pathogens from the surrounding environment after delivery, such as contact with healthcare workers or contact with caregivers. And of note, infants requiring intravascular catheterization or invasive procedures that disrupt the mucosa are at increased risk for this type of neonatal infection. And according to the article published by the AP in 2022, the leading causes of a late presentation infection in neonates were the gram-positive bacteria, such as your Coagulase negative staph, your Staph aureus, and your Enterococcus species. So according to the World Health Organization, infections were amongst the leading causes for neonatal mortality in 2019. In 2021, a systemic review and global meta-analysis concluded that despite improvements in care, neonatal mortality due to severe infection is still around 11% in high-income countries, and the Bahamas is considered a high-income country. And of note, anywhere along the spectrum of presumed infection or sepsis to rule out sepsis to suspected infection or sepsis represent the most common diagnoses seen in the newborn nurseries and the most common discharge diagnosis from neonatal units. So, based on the information I presented, I feel it's important for institutions to study their incidence of neonatal infections, and this data had not yet been studied at the Princess Margaret Hospital, so it serves as one of my rationales for embarking on this study. And the data from this study is important, and I hope that it can serve as the foundation or a catalyst for other studies to build on, and that combined data can potentially assist with decreasing the financial burden associated with neonatal infection, improve patient outcome, and aid in antibiotic stewardship. So in reference to the aim, it was to determine the incidence of the culture-positive infections in neonates admitted with the diagnosis of rule-out sepsis between the time period at the Princess Margaret Hospital, Nassau, Bahamas. And in patients 0 to 30 days old admitted to the ward nursery at the Princess Margaret Hospital between the time specified, the objectives were to determine what was the most common source of infection, whether bacteremia, meningitis, or urinary tract infection, what was the most commonly isolated pathogen for the positive cultures, and what was the most common presentation time, whether it was early or late. So the study was a descriptive retrospective chart review of electronic laboratory results in patients. The study population included all patients 0 to 30 days of age admitted to the Children's Ward Nursery with a diagnosis of rule-out sepsis during the time specific for the study, and to that end, 271 patients were included, and the minimum sample size that we needed was 267, based on the Cochrane formula and consultation with our epidemiologists. Ethics approval was granted by the Joint Public Hospital Authorities and the University of West Indies Ethics Committee, along with authorization from the Department of Records and the Office of the MCOS of the Princess Margaret Hospital to access patients' medical information on the lab system. And once that was collected, the data collection was then followed. Data for the study was collected by reviewing the pediatric accident emergency census of all patients over the years relevant. This data was done cross-reference with the census book from the ward nursery to identify any duplicates or any missing data. Once the patients were identified, their medical record numbers were recorded, and this identifier was used to confirm their age via their dates of birth, confirm their gender, and collect the relevant information in reference to the status of their blood, CSF, and urine cultures, and the isolated pathogens. Once we collected the data, the completed workbook sheets were then exported to the SPSS statistical analysis software for analysis, and of note, confidentiality was maintained throughout the data collection. So in terms of my inclusion criteria, or the inclusion criteria for the study, it was patients 0 to 30 days old who had admission diagnosis for rule-out sepsis. This was their first admission, and they were admitted to the public sector of the Princess Margaret Hospital. And so the exclusion criteria were babies or infants or neonates who are 0 to 30 days old, admitted for rule-out sepsis with other diagnoses or total other diagnosis, if they were admitted directly to the NICU, and if this was a readmission for any diagnosis of sepsis. So in terms of the results, or what we found. So in reference to the demographics, so first, in terms of gender, the bar graph shows that of the 271 patients which were included in this study, 56.8 were noted to be male, and that accounted for 154 patients, And to the far left, in reference to presentation, it was noted that 95% of all of the patients had a late presentation. And this box plot identifies the mean age of patients, where it showed that the mean age for male patients were about 18 days, and the mean age for female patients was 17 days, but the overall mean age for all the patients were 18 days, or was 18 days, rather. So in reference to the status and the pathogens, so this table shows that the blood culture status and organisms related to positive blood culture, and most patients had a negative blood culture, accounting for about 88%. However, of the patients who had a positive blood culture, which was about 28 cases, or 10%, the most common organisms seen were staph epi, coagulase negative staph, E. coli, and they all represented about 18% of the 28 positive cultures. And this is just a bar graph showing the statuses on negative, positive, and sample not received. In reference to CSF cultures, it showed that more than 90% of patients had a negative CSF culture, and this number was 249 of the 271. And of the 3% of positive cases, group B strep, represented 50% of all of the positive cases. And the next most common organism was E. coli, with 2 cases, or 25%. And in reference to urine cultures, it showed that 88% of all the cultures were negative in terms of urine culture, and that was a number, 239. And of approximately the 10% of positive cases, E. coli was the most common organism seen, followed by Klebsiella, representing about 30% of all the positive cases. And in reference to a finding that we saw, this chi-square test indicated that there was a significant association between having a positive blood culture and having a positive urine culture. And the p-value was actually 0.01, which is significant. So specifically among patients with a negative blood culture, the majority of patients also had a negative urine culture. And conversely, among patients with a positive blood culture, a high percentage were seen to have a positive urine culture as well. Of note, this chi-square test was done for blood cultures with CSF culture and between CSF culture with urine cultures. However, there was no significance seen, indicating that there was no association between those. So in reference to the discussion, so based on the aim and objectives outlined for this study, the results showed that the incidence of this group in reference to positive cultures was about 23%. It also showed that bacteremia was the most common infection at about 46% of all cases. E. coli was noted to be the most common organism associated, and this result was similar to a result done by Bell et al. While evaluating neonatal sepsis in Jamaica in 2005. They found that E. coli, Klebsiella, and group B strep were their most common isolates. Further, a study done at the University Hospital of the West Indies in 2008 showed that E. coli was the most frequent cause of urinary tract infection, followed by Klebsiella species. And in a more recent study done by Stahl et al. Between 2015 and 2017, they found that E. coli was the most common frequent pathogen isolated. Next was group B strep, and this was of their 235 cases of newborns with bacteremia and UTI. In reference to the presentation, we know that 95% of all the patients in this study presented after 72 hours of life. Now, in regards to this, most of the studies I saw or researched showed that the early presentation was more common. In fact, a study in 2020 showed that 55% of all their cases were before 72 hours of life. However, this result from my study might have been because we didn't study babies in the NICU due to documentation. So all of the patients came from the accident emergency. And usually at a hospital, patients are admitted to the maternity nursery for about 48 hours before they go home. And so those patients, if they have any sign of infection or sepsis, will go straight to the NICU. And so that will be the early presentation. So in conclusion, infections remain one of the leading causes of mortality in neonates, and it's important for institutions to endorse research to reference neonatal mortality so that we can compare results before and after the institution of certain recommendations and practices, so we can see if there was a change or decrease in the incidence, to possibly assist with identifying improper techniques and practices in reference to sourcing cultures or obtaining cultures, and overall to improve patient outcome. Thank you. These are the acknowledgements I had, and these are my references.
Thank you very much, Dr. Green. Okay, so we're going to very smoothly move on over to Dr. Leah Hanna, who is also hailing from Bahamas, but she's actually in the Bahamas. And so I'm just going to make sure with our tech team that they're good to go with Leah's presentation. She is a fourth-year resident, similarly, and she is keen on doing pediatric cardiology and critical care. Boy, critical care is really getting everybody excited. And what is quite amazing about Leah is that her plan, when she has a little bit more time, is that she's going to be traveling the other many countries, cruising to see all of those other countries. She has already done 20. I'm very jealous. So my tech team, are we ready to go? We're waiting on them. Okay, so Bahamas, can you screen share and proceed? Perfect.
Good evening, everyone. My name. Can you hear me? Hello?
Very well.
They can hear me?
We're hearing you and seeing you.
Good evening, everyone. Like they said, my name is Dr. Leah Hanna. My topic this evening is going to be the prevalence of COVID-19 infections, as well as complications in the pediatric patients admitted to the hospitals of the Bahamas. Special thanks goes to my supervisors, Dr. D. Saunders and Dr. C. Sinkley. So a little bit, I have nothing to disclose in relation to this presentation. We'll go through an outline, the introduction, aim, objectives, methods, as well as results and conclusions. So just a little bit, the COVID-19 virus is commonly called COVID-19. It is a part of the severe acute respiratory syndrome, COVID-2. It's a part of the family Coronaviridae, and it's the 19th serotype identified, hence COVID-19. This virus is enveloped and a positive single-stranded RNA virus with a glycoprotein spike on its surface, resembling a crown, hence named the coronavirus. Now, the World Health Organization actually declared the SARS or COVID-19 a pandemic on the 11th of March, 2020. There were 3 international waves that corresponded to the 3 variants. The first wave was noted to be the Alpha variant, which happened between March and December 2020. The second variant, which was the Delta variant, or second wave, happened between January 2021 to October 2021, and that originated in India. And the third wave, which is the Omicron, which originated in South Africa, started in November 2021 to December 2022. So the American Academy of Pediatrics in October of 2022 actually looked at a systematic review of case reports and cohort studies from the period of December 2019 until April 14, 2020. What they found is that they found that 60% of the pediatric population who tested positive for COVID-19 in Spain required admission, while 10% of that 60% actually required ICU admission. They also found that in the United States, 20% of the pediatric patients actually were admitted, and 2% were admitted to the intensive care unit with a mortality rate of 0.1%. Now, according to M. Bradford, in 2022, up to date of January 2022, there were approximately 9.5 million children tested positive for COVID-19. They determined that the Omicron variant was the most virulent because 20% of these cases were actually between the first 2 weeks of January 2022, which was the Omicron variant. Okay. Moving on to the Caribbean, there was a pan-Caribbean study that entitled The Caribbean's Perspective of COVID-19. What it was a cross-sectional study of 15 different Caribbean countries/territories. Those included Anguilla, Antigua, the British Virgin Islands, the Bahamas, Barbados, Cayman Islands, Cuba, Grenada, Guadeloupe, Haiti, Jamaica, St. Lucia, St. Kitts and Nevis, Trinidad and Tobago, and Turks and Caicos Islands. And what they determined was that 20% of all of the positive COVID patients actually were of the pediatric population. And their mortality rate was actually 0.24%. When relating to the United States, their mortality rate was only 0.1%. So my study, we wanted to determine the prevalence of COVID-19 admissions, along with the complications in the pediatric population in the tertiary hospitals in the Commonwealth of the Bahamas. How did we go? What did we want to look at? We wanted to evaluate the proportion of pediatric patients that actually tested positive for COVID-19 in the Bahamas. We wanted to look at the percentage of the pediatric population that was admitted who were positive for COVID-19 in the Bahamas. Also, we wanted to know what percentage of these patients had complications due to COVID-19, with the example of multi-inflammatory systemic disease in children. And we also wanted to look at the percentage of pediatric deaths that were associated with COVID-19, and also to identify any association with medical, socio, and demographic profile factors that interested in this study. Now, how did we achieve this? It was a retrospective cross-sectional study between the period of March 2020 to December 2022. We looked at all admitted pediatric patients in all tertiary hospitals of the Bahamas who tested positive for COVID-19. So just a little bit of the Bahamas, about the Bahamas, is that we are an archipelagic nation, which means that it's made up of over 700 islands. Now, we have on our nation's capital, which is New Providence and Nassau, we have two institutions. We have a public institution, which is known as Princess Margaret Hospital, which is a 400-bed facility, as well as we have Doctors Hospital, which is a 75-bed facility, and it's a private institution, both located on Nassau, New Providence, the island. Nassau actually accommodates 50% of the Bahamas population, which is about 450,000 people, as opposed to the last census done in 2021. Now, moving along to another island, Grand Bahama, that actually represents 20% of the Bahamas, the Bahamian population. We have one public facility, tertiary hospital, the Rand Memorial Hospital. That is an 85-bed facility. Now, how did we evaluate these patients? We actually reviewed the medical charts of all those who tested positive for COVID-19 who were admitted. Now, we use our real-time polymer chain reaction as well as our COVID antibody testing. What did we find? We noticed that all patients that were positive for COVID-19, we had 140 patients. However, only 130 charts were able to be reviewed. In Princess Margaret Hospital, which will make up the lion's share of all the admissions. We had 92 eligible patients. However, only 85 notes were able to be reviewed. In Doctors Hospital, most of their documents are electronic, and all 20 patients, all of their notes were able to be reviewed. I'm moving along to Grand Bahama with the Rand Memorial Hospital. They had 28 eligible patients. However, only 25 notes were able to be reviewed. What did we find? We noticed that the average age in the public institution, which would be in the Princess Margaret Hospital and the Rand Memorial Hospital, had an average age of those testing positive for COVID-19 of 6.5 years, with a 5.6 and 5.9 standard deviation. While noticing at Doctors Hospital, our private institution, the average age was actually 9 years old. However, our p-value was 0.2, which means that there was no statistical significance between the difference in age amongst the three hospitals. We noticed our weight. In regards to the Rand Memorial Hospital or public institutions, our weight was similar with 27 to 30 kgs, as well as at Doctors Hospital, the weight was 39 kgs average weight. Again, our p-value was 0.462, which means that there was no statistical difference between the weight of all three institutions. Now, a complication that we thought was common was multi-inflammatory systemic disease in children, which is MISC. It actually only accounted for 15 out of 130 patients. 12 came from Princess Margaret Hospital, and 1 came from the Rand Memorial Hospital, with 2 coming from Doctors Hospital. In regards to our mortality rate, of 130 patients that with medical chart were reviewed, only 5 deaths, which had a mortality rate and an admission rate of 3%. 4 deaths were from Princess Margaret Hospital, none from the Rand Memorial Hospital, and only 1 from Doctors Hospital. In regards to our distribution between sex, we noticed that males were 2 times admitted more than females. And we noticed that we had a person chi-square test of 1.79 with a p-value of 0.6, which means that there was no statistical difference amongst the hospitals. But we did notice that males were more admitted than females. So our mortality rate. So this diagram just shows the amount that most of our patients had recovered and were alive. And it was only 3.7% of patients from PMH had deceased, and the 5% of Doctors Hospital had deceased, simply because Doctors Hospital had the least amount of patients. They had 20 patients, and only 1 had passed, and so therefore that was a high percentage of 5%. So our symptoms. The most common symptom that was seen by patients who tested positive for COVID-19 was fever, and that made up 63%, following with respiratory symptoms of 30%. Now, in results to our 3 international waves, now despite in the earlier, as I mentioned, they noticed that, and Bradford noticed that Omicron, which was correlated to the 3rd wave, is actually the most virulent in children. In our study, we actually noticed that the 3rd wave was not the most virulent. It was the 2nd wave, which is Delta variant, which was most virulent. However, they had similar virulency with mild predominance in the Delta wave. Now, this slide here shows the complications as well as the comorbidities associated with those who had tested positive for COVID-19. We noticed that the most common complication was that of COVID pneumonia, followed secondly by the exacerbation of chronic medical illness. The most common comorbid condition was sickle cell anemia, and MISC only made up 11% of the complications faced with persons who were positive for COVID-19. So what did we conclude? We concluded that in the Bahamas, the COVID-19 pandemic resulted in low admission, positivity, as well as mortality rates. We also noticed that males had a 2-fold increase in admission in regards to females. We also noted that there was a mild predominance of the 2nd wave in compared to the 3rd wave, which was different from the studies that we were looked up. MISC had a low admission rate of 11%, but had significant morbidity, but no mortality. And our mortality admission rate was 3 to 5%, whereas a national mortality rate of 0.01%. And thank you.
Thank you very much, Dr. Hannah. Okay, so we're now at the end of session 2, and I'm going to ask you all who have your questions online to put them in the chat if you wish, and I'll open the floor to those of us who are here if there are any questions. I see Dr. Lewis, and then Prof. Trotman thus far. I think Prof is going to sneak and go first. Go ahead, Professor Trotman.
It's not on there. Sabotaging me. Hello? That's Jillian sending.
It's on now.
Hello? Okay,
Yes.
all right. Once again, I'd like to thank the presenter for their, their contributions to this forum. My question is for Dr. Green. So, several questions actually. I noted that you said it was electronic records that you had utilized, but you did not include the neonatal intensive care unit where babies are admitted directly from birth. So therefore, more or less, your study would have only dealt with late onset sepsis. However, I saw in your discussion, you made comparisons with studies that would have been from birth right on. So I was just asking, how valid do you think those comparisons would be? Because you were looking at a totally different population. And I also wanted, you gave us the most common organisms, but I didn't get in terms of sensitivity and resistance, and what was the clinical impact on that. So for instance, the babies who did not survive, what was the most common organism you found in those babies? I'll stop here and send on to...
That's fine. Hello? Okay. So to answer the last one first, so all of the babies in the study, none of the babies died. All of them were discharged. And in reference to the sensitivity pattern, we didn't include looking at the sensitivity to specific organisms. So we want that to be a further study, so that's why we didn't have that information. And you are correct. Most of my population was the late onset because of that limitation where we couldn't get the documentation from the NICU. And so it is no, it wasn't electronic at the time. There was some backlog of documentation to reference the NICU, so that information wasn't readily available to us. So I wasn't able to get it. And so, yes, I do agree with you. In comparing the studies, it would have some bias, why ours was more late versus early, and it would also lend to why the organisms were what we saw. But that was all. We accounted for that in the discussion and the conclusion. Oh.
Dr. Lewis?
Thank you. My question is for Dr. Shaw.
Okay, you can see.
You demonstrated that there was an increased incidence, I guess, of type 1 diabetes as well as DKA in the pandemic period. Did you see any relationship, and I don't know whether you looked at that, between the experience of COVID, meaning do you think that these patients had COVID-19 and therefore that precipitated their presentation in DKA or type 1 diabetes, or did you have an explanation for that difference?
No, we didn't find so. We did account for the patients who were COVID-19 positive, who did present either newly with type 1 diabetes or with DKA, but we didn't find that there was a significant difference.
Oh, I thought you were passing it for another question, but if you could just hand Dr. Melbourne Chambers.
Hi, this question is for Dr. Hannah.
Okay, so you can sit.
I just wondered if she hearing?
Dr. Hannah, just double checking that you can hear us.
Yes, ma'am, I can.
And you're hearing the question from Dr. Melbourne Chambers?
You can
Go
hear
ahead.
me?
Yeah.
We're hearing you.
Dr. Hannah. Just wanted to know if all admissions during the period, all pediatric admissions were tested for COVID antibody. I presume they were all swabbed for COVID PCR, but did they all have COVID antibody testing?
No, no, ma'am. So not everyone had antibody testing. Only those patients who we suspected had MIS-C who had a negative RT-PCR would have had antibody testing.
So do you think then you could reasonably um, estimate the prevalence of COVID admissions if you weren't testing everyone?
We tested all admissions. All admissions had a RT-PCR real-time polymerase chain reaction test. Now, for those who we suspected had MIS-C and their RT-PCR was negative, those are the patients who we followed up with COVID antibodies. So everyone who was admitted during that time period had a COVID positive, either a positive RT-PCR or they would have a positive antibody, and so that's how they became a part of the study. So yes,
Right.
everybody during that time period was tested for COVID essentially.
Okay, so I'm just wanting to understand, was it the prevalence of COVID? I don't have a new title. Infection and complications. So were you only counting those who are COVID PCR positive, or were you adding into that numerator those who were COVID antibody positive?
Both.
Right, and so I have a little issue with that. If you were not screening all your admissions for COVID antibody.
Thank you, Dr. Melbourne. I don't have any other questions online, but we have one more question here from Prof. Christie. Go ahead, Prof.
Hi, Dr. Leah. Is it Hepburn?
No, Hannah.
No. Oh, she's married. Lovely. Congratulations. Yes, Dr. Hannah. My questions mirror the ones that were just asked, but I'm taking it a little bit further. If you had to wait for the antibody test to include or diagnose Miss C, how then did you take care of the patients when they presented? The PCR test comes back immediately, but the antibody and tests take some time. That's one question. And the second question has to do with in situations where the patient was PCR negative, you're seeing the patient now, they would fit the Miss C criteria. If indeed, my issue has to do with if the child is not positive for PCR and speaks that they have Miss C, do you not make the diagnosis of Miss C?
No. To answer the first question, we never waited. We understand that, well, first of all, we do not have the COVID antibodies at the public institutions. They're only offered privately. We did not wait for the antibodies to be positive in order to go ahead and treat. We actually treated first, and then once we confirmed the diagnosis later on when antibodies were available for us testing. Sorry, if you could just repeat the last question for me, I just didn't quite get that one.
Well, I'm wondering then if you didn't count those as Miss C? You didn't, if the antibody test was not positive. But the thing is, antibody testing came in very late.
Yes.
It came in very, very late, right? And the CDC and the WHO recognizes that if a child presents as Miss C, fits the diagnosis, it's a diagnosis of suspicion because you cannot afford for a child to die, a child to go into shock, a child to go into the ICU, right? And it's probably best done prospectively. So I guess I have some issues around how did you categorize that these children had Miss C or did not have Miss C? And could it be that you might have missed some?
So we did use the CDC as well as the World Health Organization criteria, but And in regards to the antibody test, one of them was either being positive for COVID or had a recent infection. So even if the COVID antibodies were negative, but we had we didn't include them. Unfortunately, we didn't include them in the study, but we still would have treated them as MISC. They would not have been
And
included in
did
the
you use
study.
IgG, IgM, or both?
We did.
Which
We did
antibody
both
tested it?
IgG
Okay.
and IgM.
Okay, thank you.
Okay, I'm going to bring our questions to an end. And I'm now going to, with much pleasure, welcome one of my favorite people, Ms. Genevieve Sidial from Abbott Nutrition. They have very graciously granted us funds to make this a possibility once again. And so we're very happy to have Genevieve with us and to share with us on her product. Thanks, Genevieve.
Thank you so much. Good evening, everyone. Prof. Pear, Prof. Christie, and all the ones I see every day and harass. I'm not going to be here long. I'm introducing a pre-recorded presentation because just like what I did a while ago, I would have used up all the time looking at you and smiling and talking, right? So I want to say congratulations to all the presenters and the ones that I'm yet to hear, and whoever does get a prize or anything, congratulations. And if you didn't, you did awesome. So I'm enjoying this thing. So today, we're going to be talking about Paediatric. Sometimes it's taken for granted, and sometimes it is seen as a real gold rare find and have to have. So I want you to just listen to this presentation. Thank you so much. We are talking about intervening early to help children get back on track for growth. Thank you.
This graphic represents a pediatric malnutrition consensus statement in 2015 of the American Society for Parenteral and Enteral Nutrition, ASPEN, and the Academy of Nutrition and Dietetics. It says that 1 out of 8 children in the USA has at least one indicator for undernutrition and 1 out of 40 for moderate to severe undernutrition. This poster was presented at the 5th International Conference on Nutrition and Growth and shows that undernutrition will impact children regardless of age, race, or ethnicity and income levels. Now, the reasons are many and common, and they include illnesses or just poor eating habits. So, not getting enough protein, calcium, and vitamin D will result in issues you may see. So yes, there can be delayed growth and development, but look at the issues that are not obvious at a glance. Undernutrition compromises immunity and the development of brain and eye. This chart then simply underscores the balanced nutrition that Paediatric delivers. Not only calories, but nutrients that support muscle and bone, immunity, brain, and eye. Paediatric is clinically proven to help children grow with a good source of high-quality protein, 25 vitamins and minerals, DHA omega-3, lutein and choline to support brain and eye. And yes, it is suitable for lactose intolerance. We suggest that the success of Pediasure is to get the child back to the family pot with healthier eating habits. Pediasure is a bridge for short-term nutrition support. In Jamaica, we have 3 options available in the supermarkets. Pediasure Grow and Gain, 240 calories, 7 grams of protein. Your Pediasure Grow and Gain with fiber, 240 calories, 7 grams of protein, but 3 grams of fiber. Pediasure Grow and Gain and the Grow and Gain with fiber remain the nutrition support standard for your patients 1 to 13 years of age, delivering much more than calories for sole source nutrition or crucial supplementation, and they are found in the inventory of most of your hospitals. Take a closer look at Pediasure Sidekicks for a reduced calorie option with 40% more protein and 3 grams of fiber. Here is Pediasure Peptide, mainly found in your hospitals, and it answers your search for a hydrolyzed protein formula for the child 1 to 13 years of age. Pediasure Peptide contains unique ingredients to improve digestion and nutrient absorption to help your patients thrive. Pediasure Peptide comes with structured lipids and MCTs, a special blend of fat that enhances absorption and tolerance. Your patients with any underlying condition that results in fat malabsorption could benefit from your Pediasure Peptide. Structured lipids can help reduce muscle catabolism and improve nitrogen utilization for protein synthesis during metabolic stress. Your short-chain fructooligosaccharides, SC-FOS, is a prebiotic fiber that fuels the beneficial bacteria in the gut. It stimulates bifidobacterial growth and activity, altering the colonic flora in favor of a healthier composition. Pediasure Peptide is a good source of zinc, vitamin D, and antioxidants to support the immune system. So don't forget, Abbott Nutrition has a complete portfolio of specialty products for infants and children. They differ mainly by the structure of the proteins and are considered when there are any nutritional concerns as listed here: inadequate food intake, increased protein needs, poor weight gain and growth. And so, any chronic condition that presents with intolerance to intact or hydrolyzed protein, with abdominal pain and cramping, malabsorption and maldigestion, nausea and vomiting, loose stools or chronic diarrhea, stool with blood and mucus, your standard intact protein or your peptide-based or amino acid-based formulation are options for your nutritional interventions. We know that optimal nutrition is a shared responsibility, and again, we are honored to have you as partners, so we thank you. For any queries, please do not hesitate to contact your Abbott Nutrition representative. Optimal nutrition is our shared goal.
Thanks again to Abbott Nutrition for making this possible. We are very, very grateful to you all. Thanks very much, Genevieve. All right, so we're on to our third and final session. I don't want you to let the energy wane. I need you to pep it back up again. Those of you online, you can stretch. I won't hold up anybody here to stretch. But we're going to move on to our third Bahamian, Shade Lopez, who always has a bright smile to greet me. It's wonderful. She has studied both here in the Caribbean as well as overseas in Canada. She has come back home. She loves when she has the time to make sure she's looking fabulous like this evening. And she loves to spend time with her family and her bestie, Stormy. That's the fur child, the four-legged one. So I'm going to welcome Sade now to join us and speak to us on the prevalence of food insecurity in children attending public clinics in New Providence, Bahamas. Dr. Lopez.
Good evening, and thank you for having me. My research project was themed the prevalence of food insecurity in children attending public clinics in New Providence, Bahamas. I had the honor of working with Dr. Sherelle Lockhart and Dr. Frankson. We will take the outline of an introduction, go over the rationale, aim, objectives, methods, results, and conclusions throughout my study. Now, many of us are familiar with those beauty queens that go up to the stage and say that our goal is to end world hunger and achieve world peace. Well, while many strides have been made globally to end world hunger and achieve food insecurity continues to be a significant burden to many. And by food insecurity, or food security, I should say, it is the consistent access to food that is nutritious and enough to sustain normal growth and development. The Sustainable Developmental Goals, also known as the Global Goals, were adopted by the United Nations in 2015 as a global initiative and a call to action to end poverty, protect the planet, and ensure that by 2030, which is just 6 short years away, all people enjoy peace and prosperity. In 2016, the Food and Agriculture Organization of the United Nations noted that 10,000 of the world's population suffered from food insecurity. That translated to 680 million people. By 2022, that number had increased to 29.6% of people, or 2.4 billion people on the world's population, experiencing moderate to severe food insecurity. Among them, 11.3%, or 900 million, face severe food insecurity. Because of the food insecurity issue, the Food and Agriculture Organization of the United Nations started collecting data about food insecurity. This was done via the Food Insecurity Experience Scale, which is an 8-part questionnaire. It allows persons to collect experience-based direct responses about food insecurity on an individual or household level. Why did we choose this survey? One, it was easy to apply. It was cost-effective to distribute. It was available in numerous languages. In the Bahamas, we have a large Haitian population, and the the Food and Agriculture Organization actually provided a Haitian Creole translation for the survey, which made us able to include our Haitian counterparts in the study. It also allows us to collect timely data that can be used to compare across countries and other subpopulations. If you look to the right of the screen, you will see the world's map. And the colors the countries that are denoted with a dark green color are countries that consistently report FIES data or similar metric-based, experience-based measurement scales about food insecurity. The other ranges of colors show countries that are adopting different stages of reporting on food insecurity, where gray shows that there is no data that has been collected. Now, the Caribbean accounts for a very tiny population of the world's map, but if you look very, very closely, you will see some dark green dots on there. And so the Caribbean has been reporting on FIES data. What is the rationale behind this study? For one, food security is a basic human right. Identifying the prevalence of food insecurity can assist policymakers in initiatives to end food insecurity, and thus do our part to contribute to the Sustainable Developmental Goals in 2030. Food insecurity affects the entire family. This includes children. And as advocates for children, we, aspiring pediatricians like myself, should take a special notice and care about things that affect them. We also noted that there are increased risks of chronic, non-communicable diseases like type 2 diabetes, hypertension, hypercholesterolemia that was associated with food insecurity as it applies to people on the whole. This could possibly be due to a paradox that is observed called the food insecurity obesity paradox, in which people who are food insecure or have low food security may consume higher caloric foods in an attempt to just maintain having consistency in meals. Additionally, food insecurity in children has been linked to delayed development in children, increased risk of chronic illnesses like asthma and anemia, and behavioral issues like hyperactivity, anxiety, as well as aggression. And what I don't have listed here too is that in those subpopulations of children, they are also at increased risk for low self-esteem and bullying. So our aim was to determine the proportion of families attending government-funded clinics in New Providence, Bahamas, that were food insecure. And we hypothesized that at least 20% of these families would be food insecure. Similarly, our objectives were the same. The prevalence, in this case, of moderate to severe food insecurity amongst these families in New Providence. And the reason why we use moderate to severe food insecurity is because that's what the FIES survey interprets. Additionally, we had a small subsection of our survey that looked at really the attitudes of patients towards healthy eating. We looked at what if they thought they understood what a healthy diet was, and a lot of other questions that included how much times they would eat takeout throughout the week, as well as how much times they would eat food that they understood to be a healthy plate. Data collection commenced following approval from the Ethics Committee, the Public Hospitals Authority, and the Ministry of Health. A cross-sectional survey was administered using a convenience sampling method, and the study was conducted in government-funded clinics, in Flamingo Gardens Clinic, Elizabeth Estates Clinic, Anstown Clinic, as well as the specialty clinics at the Princess Margaret Hospital for pediatrics. This occurred between June and August of 2023, and our target population included families that were seeking care at government institutions in New Providence, Bahamas. Of the 170 participants that were a part of the study, we found that the Bahamian nationality, no surprise, was the most prevalent. We also found that the majority of the participants were between 18 to 30 years of age and single. Most persons had up to a secondary school education level, and 70% of individuals earned less than 20,000 Bahamian dollars per annum. Now, when we look at the raw responses of the FIES survey, which is simply a yes or no answer to the 8-part questionnaire, which I will go over for you. Question 1 asks if you were worried that you or your family members did not have enough food to eat. If you, 2, were unable to eat healthy food or nutritious food. If you or your family only ate few kinds of foods. If you or your family members had to skip a meal. If you or your family members ate less than you thought you should. If you or your family members ran out of food, were hungry and did not eat, or went without eating for a whole day. This survey is designed that the more severe questions are towards the end of the survey, meaning that they are at a higher level or higher indication of food insecurity. 27% of people of the population noted that they were worried. 29% felt that they were unable to eat healthy and nutritious food. 27% felt like they ate only few kinds of food because of a lack of access to consistently nutritious food, whether that is because of money or other reasons. 21% said that they skipped meals. 24% said that they ate less than they thought they should, and 15% said that they actually ran out of food. 17% said that they were hungry and they were not able to eat, and 11% actually went a whole day within the last 12 months, which was what our survey looked at. It was actually the 12-month study. Over the last 12 months, they actually went a whole day without eating. The information was inputted into the app that is provided by the Food and Agriculture Organization of the United Nations. Of course, strict confidentiality was maintained, and our output showed that 21% of people in the study experienced moderate to severe food insecurity. Of that, 13% experienced moderate, and 8%, or about 8%, was actually 7.8%, experienced severe food insecurity. When we speak of moderate food insecurity, we typically speak of those people that have to eat less variation in food or smaller amounts of foods because of a lack of access, because of money, or other reasons. And the more severe persons would actually have to skip meals or not eat at all. So how does this compare to the global standard? Globally, so the FIES also provides a global standard for which we can compare our data to. And it was found that globally, 27% of persons experience moderate to severe food insecurity. So our number was slightly less than the global standard. Additionally, significant results were found Even though we experienced less food insecurity than the global standard, there were some discrepancies that made us differ from the global standard as well. We found that the items few food and skipped, meaning that they ate less variety of food and sometimes skipped meals, were higher amongst our population than the global standard. When we looked at the demographic analysis, we showed that lower education levels were correlated with a higher level of food insecurity, as well as higher incomes were associated with a lower level of food insecurity. 89% of participants felt, and when we looked at our healthy food beliefs, we found that 89% of participants felt that they understood what constituted a healthy diet, but only 21% of them claimed to consistently eat that. Approximately 85% of people noted that they reported eating takeout 1 to 3 times weekly. Additionally, in conclusion, the data collected, we found, was able to reliably predict the prevalence of moderate to severe food insecurity amongst our population in the study. The results of the data confirmed the study's hypothesis that 20% of participants experienced food insecurity. It is our hope that this body of work can provide the framework for further research into at-risk populations and help to identify food insecurity risk factors among said populations in an effort to decrease the overall food insecurity in the Bahamas and eventually the world. Our new initiatives, can be implemented to provide consistent, nutritious food to decrease the prevalence of food insecurity. I'd like to say a special thank you to everyone listed who contributed to making this project a success.
Thank you very much, Dr. Lopez. Okay, so now we go back online to Dr. King, who has the pleasure of being our final presenter. Dr. King is also from the Bahamas, spent some time similarly in Canada, and it was interesting to note that he is also very much into swimming and has started a swimming program for children in the Bahamas. So, Dr. King, it's your turn now to present to us on COVID-19 vaccine hesitancy and parents' willingness to vaccinate children ages 5 to 11 years with a medical condition. Over to you.
Good afternoon. You guys can hear me?
Yes, we can, and we're seeing your slides as well.
Okay. Good afternoon, everybody. My name is Dr. King. My supervisor for this presentation was Dr. LaShawn McKenzie. So the topic for my presentation or my research was COVID-19 vaccine hesitancy and parents' willingness to vaccinate children's ages 5 to 11 years with a medical condition at the Princess Margaret and the Round Memorial Hospital, Bahamas. The COVID-19 pandemic, which emerged in the late 2019 and persisted into 2023, brought to light a complex of interplay factors influencing public acceptance to vaccines worldwide. The Bahamas' total cases of COVID-19 was 38,084 cases as of February 26, 2024, and our total deaths were 844 cases on the same date. Understanding the willingness and hesitancy among the general population to embrace COVID-19 vaccine is crucial for effective public health strategies. It is noted that the Pfizer vaccine was initially approved to be administered for children ages 12 years and over, and then it was finally brought to the Bahamas for children ages 5 to 11 in June 2022. The term vaccine hesitancy either means a refusal or a denial in getting the vaccine. Some of the main factors that promote this phenomenon are the parents or the parents' confidence in the vaccine, convenience, and complacency. For the population to accept the vaccine, it must be generally accepted that it is safe for everybody's well-being. One of the studies that was the catalyst for my research presentation was a study done in Italy where they looked at 490 children with comorbid conditions, and their results showed that 38.8% of the study sample were willing to vaccinate their children based on the following criteria. Parents themselves had to actually have been vaccinated, parents who had a higher education, and a perceived risk that their child who already had a comorbid condition could become infected with COVID-19. Hesitant parents represented 26.3% of the population in that study, and they represented from parents from the low socioeconomic status, parents who have not been vaccinated from COVID-19, and perceived lower risk that their child would actually contract the COVID-19 vaccine. Overall, they concluded that the vaccine willingness was far behind the studies that was done in Canada and Brazil. And this was the reason why I decided to do this study in the Bahamas. The aim of the study was to assess the willingness and hesitancy of parents of children ages 5 to 11 years with one underlying medical condition in the Bahamas to administer the COVID-19 vaccine and to identify the factors that influence their decision making. Our objectives, we looked at the demographics of the participants. We wanted to determine the extent of willingness of the study participants in giving the COVID-19 vaccine. We also wanted to determine the degree of hesitancy of study participants in giving the COVID-19 vaccine to their children ages 5 to 11, to identify the parental factors regarding consent for their children in getting the COVID-19 vaccine intended for promoting health and well-being of their children and the general population at large, and increasing the herd immunity. We also wanted to evaluate the nature of associations between the COVID-19 vaccine-related adherence factors in the parents and their level of willingness versus hesitancy, considering the study's participants' medical, socio-demographic status. The study was a cross-sectional study design, which used a questionnaire, which was administered to parents in the specialty clinics at Princess Margaret Hospital, and we also administered the questionnaire at the Rand Memorial Hospital in Grand Bahama. The study took place during the months of June 2023 to August 2023. Ethical approval was given by the PMH board. Questionnaires were then handed out in the specialty clinics during Monday to Friday at Princess Margaret Hospital, and on Monday in the Rand Memorial Hospital, Grand Bahama. Surveys were then completed and given out by health professionals, which included nurses and doctors. Informed consent was given to all parents completing the survey, and their identity was not divulged during the whole procedure. It was important to note that the questionnaires were kept in a locked safe inside the specialty clinic during the procedure of the research study, and was then collected and taken home at the end of my study. Data collection was then performed, and no personal information was given out at this present point in time. It was then initiated and extrapolated to the Excel spreadsheet, and then we worked along with the data statistician to put it into the SPSS software for analysts. The statistics used in my research included descriptive statistics, which were used to summarize the data to provide a general overview of the participants' characteristics and responses. Inferential statistics was used to test the hypothesis about the relationships between variables. Spearman's correlation was used to measure the strength and the direction of association between two ordinal variables, such as willingness to vaccinate and perception of the vaccine as a health risk. And one multiple linear regression model was used for one quantitative dependent variable and various multiple dependent variables. The level of alpha test that was used to test the hypothesis was 0.05, and this means that there was a 5% chance of making a type 1 error, which represents a 95% confidence interval. Going to the results of the study, the parent demographics of note in the specialty clinics was about 87% female and 12.8% male. The medical conditions that we encountered in specialty clinics, the number one was asthma, above 25%. Secondary was patients who had underlying neurological disorder. Sickle cell came in at third, and then we had to categorize a lot of medical conditions that only had about one answer as other, just to make the results a bit more concise. The results showed that the willingness to vaccinate in the population, that 60% of the population did not intend to vaccinate against COVID-19. Little less than 20% was somewhat likely to vaccinate. And it also showed that there was only about 10% of the patients who definitely were willing to vaccinate against COVID-19 out of the sample population. As it relates to hesitancy in my results, it was noted that a vast majority of the population was absolutely hesitant to vaccinating, and about 10% was quite hesitant, and only about 20% was not hesitant in the future to vaccinate against COVID-19. Some of the reasons for not vaccinating included vaccine safety at almost 45%, lack of information of the vaccine at just about 30%, and there are thoughts about the effectiveness of the COVID-19 vaccine at about 15 to 17%. In looking at the Spearman's correlation, there was a significant negative correlation indicating that parents who viewed the COVID-19 vaccine itself as a health risk to their children were less willing to vaccinate. And there was also a significant positive correlation indicating that parents who viewed the vaccine as a health risk were more hesitant to vaccinate their children for COVID-19. In conclusion, the study reveals a concerning trend of low willingness and high hesitancy among parents regarding the COVID-19 vaccine for their children. Various factors influencing parental decisions include safety concerns, access to reliable information, perceived effectiveness of the vaccine, and individual health risk perception. One notable finding that we found is that a large percentage of parents do remain neutral about perceiving the vaccine as a health risk for their children. And the study suggests that with adequate and accurate and truthful information dissemination, neutral parents may be more inclined to commit to vaccinating their children as a preventative measure against a severe illness. These findings carry significant implications for public health policy and practice, highlighting potential barriers and challenges to achieving high vaccination coverage among this population group that was studied. And with that said, I'd like to thank you for your time.
Thank you, Dr. King. Okay, so now we can entertain questions for our two presenters in section 3. I'm going to start this time with a question from the online group. And our Dorset is asking, Dr. Hepburn, any factors that contributed to more males hospitalized than females, and does that correspond, or did that correspond with the global distribution of COVID admissions? So that's not really for this session, but the question came in after.
Okay, so in regards to reviewing the literature, they actually said that the double X chromosome actually provided more innate and adaptive immunity, and so that's why males were more likely to be admitted, and also the progesterone was actually a protective factor of getting viral infections that females have. So yes.
Okay, so are there any questions from the group in here for our last two presenters? And I'm not seeing any yet on my chat, and Dr. Garbett has not informed me of any yet. Yes, Prof. Pear, Brittany, straight across. Right across, right there.
Thank you. Thank you again, presenters, for the final session. And my question is, Dr. Lopez, did you disaggregate the data between the Bahamian versus the non-Bahamian participants? And if you did you notice any significant differences?
Thank you, Prof. Pear, for your question. So we did compare, so I should note, sorry, that of the 170 participants that we had, 95, almost 96% of them were between Bahamian and Haitian. I actually found that there was no statistically significant differences between the data collected between the Haitian population and the Bahamian population. I'm not sure if this could have been due to the sampling method that was used or the fact that other community clinics might have had higher population of Haitian participants in other portions of the Bahamas, like Family Islands as well, that might have affected the data. But in this population that I had, I did not find that there was any difference.
And Prof. Gossel Williams?
Yes, thank you very much, Dr. Harrison. I have a follow-up question for you. Your objective mentioned families, that you're looking at food insecurity in families. So your participants, who were the participants, the parents or the children? Who was it that you actually administered the questionnaire with?
The questionnaire was administered to the parents, but as a part of the inclusion criteria, there had to be a household that had children in it, so to make it more relevant to pediatrics.
Okay. So, and I'm speaking as a non-pediatrician
Yes, ma'am.
and more on the perspective from a mother. Sometimes parents may not eat and they ensure that the children are fed. So I'm trying to figure out, how did you conclude that the food insecurity by the participant translates to food insecurity in the child?
Well, it was under the thought process that if the household, because the question was not just about the participant, it was actually a household question. So the question asked, did you or others in your household experience this? So in that way, it tried to encompass everyone in the household. Also, it is a well-known fact, as you have said, that mothers in particular are affected by food insecurity disproportionately to their male counterparts. And for the same reason that you outlined, they are more likely to eat less healthy food or smaller amounts because they would like to feed their children. And so that is a very true observation that you had there.
Okay. Thank you.
Are there any further questions? Let me just double check that there are none online. No. Okay, so we are going to pause briefly to allow our judges to deliberate for about 10 minutes, if that's possible. Perhaps at the top of the room or outside at the desk. We have either option available to you all, and we await with bated breath their announcement. So those of you online, we will resume at 7:38 or 8:38 if you're in Trinidad. Okay, so our judges are back, and so we will resume with our resident research forum. So I'm going to ask, I'm not going to call her the chief judge, but I'm going to call her the representative of the judges, the select person who is going to come and give us some general feedback on the presentations. Prof. Gossa-Williams.
Okay, good afternoon, everyone. Dr. Harrison, you actually described it correctly because there was a lot of deliberation and I thought that I would be the nicest and keep it the shortest in terms of the critique. I want to thank you very much for inviting me to be part of this, Professor Peer. Generally, I don't work so well at night, but the presentations did keep me awake. And Prof. Thiem and I had a little discussion about the fact this is really a good activity, and it would be good to see the rest of the faculty embrace it. What I really liked about it is the participation from the audience. And the questions asked were really critical and really helped to shape the grading that we have today. I had lots of questions, but I had to keep quiet as a pharmacologist and just let the rest of them roll. So overall, I have to commend the DM students. You represented yourself very well. Your ability to present, it was on form. Whether what you were saying was correct or incorrect, it was the presentation, so confidently done. So kudos for that. I was really impressed with the level of the research, and I have to wonder if this is the kind of work that we're putting out, why are we not publishing? You know, so we really have to make an effort to push that aspect of it. I guarantee you, students, well, you're almost out, yes, you're still students, that if you made the effort to present, to write, you'll feel even much more proud of yourselves. So I look forward to the turnout. So the overall feeling in terms of the content, for the most part, all of you presented what you were expected to present. All the elements were there. The objectives were fundamentally met, and we saw the results and the conclusion. I did see one and two where I thought the recommendations didn't really match the conclusion, but I mean, it wasn't anything that was really red flag. The scores, what was the max score on the form, Prof. Peer? Could you remind me the max score? About, is it 20 or 25? 25? Right, so the scores that we got ranged between 21 and there were one, 16. We didn't have anybody that was a clear 25, and some of the reasons why were the methods weren't necessarily fully explained in terms of how the sample was selected. If you notice one of the questions I asked, I wasn't so sure who is it that they were actually giving the questionnaire to. So some of those things we thought were deficient. We could see there were some little weaknesses in the stats, but I think for the most part, Prof. Reed must be happy with his mentoring of the liaison officers. I think we're seeing some improvements, and for the most part, the students did present what they were giving in a confident way. Terms like incidence and prevalence, they seem to have understood for the most part. All right, I'm supposed to keep it brief, right? Keep it brief. So we had a hard time deliberating who was first, and we were kind of saddened by the fact that we're not getting 3 prizes today. I think we should try next year to see if we can get some more prizes, because overall the top 3 we chose were really close. And so in the end, sadly, we can only choose one. And we thought the person that we chose was showing expertise in most areas, We thought this person had most of the content. They explained the sample size. They explained, how they collected the data well. They explained limitations. That was clearly articulated. And so we have awarded the top score to Dr. Carvalho, Alistair. And I think you saw his questions were adequately and appropriately answered, so we thought he was best. But it doesn't mean that the rest of you didn't do very well. I thought most of you did very well in terms of the questioning. And there were a couple that I wanted to probe on, and I'm sure I will find you somewhere and and ask you about it. But I'm really impressed with the group, and I wish you all the best in your exams coming up. Mm-hmm.
Thank you so much to our three judges. Thanks, Prof. Gossel-Williams, for bringing the report. And congratulations, Dr. Carvalho. I'm going to invite Dr. Melbourne Chambers to just present your award. Lovely. Congrats. Okay, so, there are some people that are just blessed with making you feel good and pleasant. Prof. Christie is one of those people, and so she's always the best person to close out any event of this nature. And she's such a senior researcher that she's the most appropriate person to come and give the vote of thanks and to close out a wonderful evening.
Good evening, colleagues. Colleagues, you understand that, colleagues, which means you must pass your exams in a few days, in a few weeks, okay. So as usual, it is indeed my pleasure, my privilege, and my honor to give closing remarks, this for the second time, in what has been a celebration, a feast, I think, of new knowledge from our newly minted resident researchers. The presentations, I thought, were clear, they were well organized, they were passionately presented, there was excellent audience participation. Thank you, Madam Moderator, overall. And of course, we all heartily congratulate our winner, Dr. Carvalho. He was my choice. And although everybody did well, I think you stood way above the rest. And you're going to make a good neonatologist. And I think you have a study behind, coming up. Mm-hmm. So, I am going to speak on behalf of your forerunners, those who presented here last year, who are already out there disseminating their research in the international space. Many gave oral and poster presentations at the UWI Medical Alumni International Conference, and they were left with cash prizes, first second, third, and they participated in both poster presentations and oral presentations. And what was interesting is that colleagues and residents who had gone on before joined in actually submitting abstracts for that conference. The Department of Pediatrics, Professor Pear, you should be very, very ecstatic and happy, because you'll remember at that meeting, it was just the pediatricians. If the pediatricians did not show up, you know, we probably would not have had resident presentations. So they have gone ahead of you and they are showing you the way. Not only did they present there, but they also presented poster presentations, I know of 2, in the Global Health Track at the AAP conference, American Academy of Pediatrics conference in Washington, D.C. as well. And Dr. Abby also presented her work, and she was the first in the Global Health section, and she gave an oral. Clap her. In addition, when I did a little survey, they're also writing their papers, and I know of at least one person who has her paper ready to be submitted. She's just asking several of us to just look it over and make some little final remarks. So, our trailblazers are joining us in the room in similarly encouraging you all to submit abstracts to the global track of the American Academy of Pediatrics conference, which this year is just in Kingston 21, Orlando, Florida, right? And it's going to be September 27 to October 1. Please write it down. All of you should submit. There are also several subspecialty international conferences that you can present in. I'm sure there are neonatology conferences and other global health conferences that are available. As an infectious diseases physician, I can speak to IDE Week, or what we call Infectious Diseases Week, where all the infectious diseases doctors all over come together to discuss issues for a whole week. And in that, we have the Pediatric Infectious Diseases Society. So you can submit your paper to that as well, too. And that conference is going to be in Los Angeles, California, on the 16th to the 19th of October. And then, of course, you'll tell me of many other international conferences that you really should submit your work to. Similarly, I'm encouraging you not to put your paper on a shelf to gather dust or put it in some electronic file and leave it there. Please engage your supervisors to get your work published. Yes, this thesis is huge, you know, but your abstract is already okay, I'm sure. It's a structured abstract. It's probably 250 to 300 words. Your background is going to be much too long. You're going to have to shorten it to, you know, maybe 600 or 700 words, 3 paragraphs. Your results, your methods are usually quite fine, you know, but you need to still shorten it. Your results need to go from the hundreds of tables and/or figures, and they need to be collapsed to 5 tables and/or figures. And your discussion, I think you're already shortening and making clear what your discussion points should be based on your presentation today. And your reference is maybe no more than about 25 to 40. And I think most journals, that would fit the criteria for most journals. Again, a lot of you are going on to do subspecialties, and this is so important. And we really need to not only do pediatrics for us here in Jamaica and in the Bahamas, but we have to remember that we are trying to populate the Caribbean with pediatricians and also with subspecialties, subspecialists. I really came across a paper recently which was done by 2 of our graduates and by somebody who is in the program, a first year Can you imagine? And it was published in Vaccine, looking at Antigua and the uptake of the hepatitis B neonatal vaccination dose in that country. And that is essentially a trailblazer. You know, so when you're finished here, you're going to continue doing that sort of work. We also need to know that your published paper, your poster, or your oral abstract that is presented in an international setting looks great on your resume. Yeah? And when you will soon be thinking of going on to do fellowships in the various subspecialties, as I heard this afternoon, yeah? And not only will it give you your fellowship spot in an international setting, but you may even get 2 years of salary or 2 years of a stipend, you know, to keep you going. And of course, if you're coming from the government of Jamaica or the government of the Bahamas in this particular situation, then they will help you too. So so you'll have the funding you need to go off to do your work. Recently, Dr. Abby and several other members in the department collaborated with Professor Upton Allen to address the residents and have it was a very big conference looking at fellowship opportunities in Canada and at the Hospital for Sick Children. And you really, really, really need to take that up. And I noticed at least 2 or 3 of you have already been working abroad, and you came back for a little bit, but you know, you have had a taste of what it's like. You may want to go back. I also want to say that I am so happy to see the Bahamians here in presence, 2 out of 4. That is fantastic. Last year it was a smaller group and it was online. And that's really, really nice that you could be here to present to us face to face. And then finally, thanks to Professor Peer, because this was his baby, and also to Dr. Harrison, and to all the presenters, your supervisors, the administrators, the audiovisual and IT teams, for your assistance in leading, organizing, and supporting this marvelous event. Thank you very, very much, Genevieve, for supporting us as you usually do. And it's been a long time, we won't tell them from when. And again, you're not only the newest generation of graduates, but you are now the newest generation of researchers. And I am saying wherever you go, you're going to take what you learned out of this experience with you. And new knowledge is really what research is. And I was taught you write about everything you do. If you're teaching, write about it. You're implementing a new vaccine in your clinic, write about it. And you did. I loved that paper, the COVID-19 vaccine paper in the Bahamas. Whatever you're doing, just it's just generating new knowledge. So just write about it. And there are many, many different ways in which you can write about it. So I want to thank you again for the opportunity to speak. I want to thank you all for taking the time in the countless nights, working so hard. I want to thank your families for supporting. I think I saw some parents here earlier on, and I know there are partners here and so on. And I just think you should all just go for it because you're just marvelous and outstanding young people. So congratulations and carpe diem. Thank you.
Thanks, Prof. Just in case you don't realize, we're all a wrap. Have a wonderful evening. There are some refreshments outside. That's why those of you who are online should have been here for the lime post the event. Thanks again, everybody. Have a good evening.